let's get started. Welcome, everyone. I'd like to call the meeting to order and do the roll call. And if you'll acknowledge that you're here so we can be ready. Nancy Baker.
Here.
Ronnie Beal.
Here.
Carl.
Yes, sir.
Carl is here. Larry Cox.
Here.
Casey Cooper. Carolyn Cower. Joyce Edwards.
Here.
Maggie Faulkner.
Here.
I'm here. Vicki Green.
Here.
Myron Harris.
Here.
Jeff Heck. Judy Johansson. Michael Lavender.
Here.
Okay, Pat McGinnis.
Here.
Morris Pittman. Judy Poe. Mandy Stone.
Here.
Duncan Sutzer.
Here.
Ed, are you here?
No.
Okay, I didn't think so. Charles Vines.
Here.
Okay, we have four. All right, the next item on the agenda is public comment. We have two folks that have signed up, and first call on Mary Short.
So, things have been interesting. I have been attending Partners Board of Directors meetings, and I've been attending some Partners training, and they're sort of an interesting group over there. But one of the most recent things that occurred, and this has to do with relative as direct service employee, Partners put out this provider alert, and in it they tell their service providers, by law, including the innovations waiver, relatives are only permitted to serve as caregivers to certain of their own family members in unique and exceptional circumstances. Well, nowhere in the innovations waiver does it use the words unique and exceptional. It uses the terminology specific circumstances. So if you wonder why relatives view an LME MCO as an adversary, that might be one of the key reasons when they notify the service providers that it's not specific circumstances under which relatives may serve as providers, but under unique and exceptional. Second of all, I have been trying to follow what's happening on the federal level. And there was an organization called the National Consumer Voice for Quality and Long-Term Care. It was originally formed for nursing homes, but it then grew into assisted living and specifically now home and community care. And this group put out a report. And as part of their report in 2012, they talk about people receiving home and community-based services being able to have those services mandated Medicaid services. But they also talk in that report that the federal government require that consumers have the right to choose their workers and schedules for care and services. Now remember, they're working to change the federal Medicaid law, so then you all are going to have to comply. So here's the statement I want you all to understand about that. The feds should require that consumers have the right to choose their workers and schedules for care and services. Consumers were very clear that they wanted a say in who their worker is and when their services are provided. These choices are fundamental to person-centered care. Allowing consumers the choices in these areas makes care and services more responsive to consumer needs and improves not only quality of care, but quality of life as well. Without these choices, we are in essence institutionalizing people in their own homes. Just saying. Now, at the Quality and Control Committee, they presented quality improvement. They presented an innovations performance measure little report here. And on page 5, it one of the performance measures is percentage of participants reporting that their individual support plan has the services that they need. And they report that for 2014, that's 100%. That is, again, participants reporting that their individual support plan has the services that they need. And the performance measure says 100%. And then, 2 questions later, it says portion of participants who are receiving services in the type, scope, amount, and frequency as specified in the ISP. And that's only 97%. So I give up, which is it, 100 or 97? And who does these performance measures and what are they based on? Because, well, it doesn't jive with the complaints and grievances that have been filed. And I also wonder, in the complaint and grievance report here, it says that there were 133 complaints and grievances in Q4, the total number. And then it breaks it down on behalf of consumer. But it also says, it separates out the number of complaints by for North Carolina Innovation Waiver consumers at 26. So of your 133 complaints, 26 of them were IDD consumers. So that seems like a really high percentage of your complaints, considering we're this really tiny percentage of your actual consumers. So you might want to try to figure out how everything I always talk to you about relative as provider, not being allowed to work 40 hours. Oh yeah, and that's not on this complaint thing either. You don't break it out about complaints received about enforcing the supposed 40-hour recommendation of relative as direct service worker. All right, thanks, bye.
Thank you. Jerry Rice?
Thank you, Mr. Chairman, members of the board. You know, the human factor of this that we deal with is what we should be about. One of the big things that I think we need to focus on, and this board needs to hear something on, is the emergency room. The hospitals, it's a statewide problem. It's been on the news, and when I hear that we're taking care of the people, my question is, are we? We might, in our own mind and in our own little world, I don't think we're doing as good a job as what we're saying we're doing here. I'm talking about smoking. Because if it's a statewide problem and we got emergency rooms turning people away and can't find places, we're not doing a good job. What breaks my heart is something that anyone have a heart broke over. One of my little nieces, 12 years old, come to me and said, I had a little friend I went to school with. She happened to be a relative, a distant relative of ours. And she said, the little girl come to her and told her that she didn't want to go to school. And she said, why not? She said, they bully me. And they do things that I don't like. So a few days before school started, they found her dead. And she'd overdosed. So that questions, what are we doing? Are we really doing the job that we say we're doing? Or are we just making the numbers match the paperwork that we need to get the funding? That might be some hard criticism to take, but I think we need to question every aspect of everybody. Because when it comes down to a little kid looking at you in the eye and telling you they was bullied at school and they didn't get the education or whatever, that really strikes home to me. That gets down to, are we really doing a good job? This is not the only one that I've spoke about in the past, and I can't speak about them every time I come because they're different issues. But when it comes to life, that is what we're talking about. We're talking about people's lives. And when it comes down to a kid taking their life because they're not getting the help they need and the support they need, I question what we're doing here. Thank you.
Thank you, Chair. Next item on our agenda is review and approval of the agenda. At time to look at the agenda, is there a motion or is there anything to add to the agenda? If there's not, is there a motion to approve the agenda as presented?
Motion to approve.
Okay, we have a motion, is there a second? Second. Second. Any questions or comments about the agenda? All in favor of approving the agenda, say aye.
Aye.
Any opposed? Okay, that's unanimous. Next item is review and approval of the prior meeting minutes. You can remember way back in June, we had our last meeting. That was our meeting, our minutes. Everyone had a chance to review the minutes of the meeting. If so, is there a motion to approve the minutes as presented?
So moved.
Who made the motion? Okay, we got it. Ed, second. Any questions or comments about the minutes? All in favor of approving the minutes, say aye.
Aye.
Any opposed? Okay, the conflict of interest disclosure, Tracy?
Yeah, this is the time during our meeting, if any board members have developed any new conflicts of interest related to their appointment to the board that you have not disclosed or the conflict of interest disclosure.
Can't hear back
You
here.
can't hear that louder.
Sorry. If any board members have had any new conflicts of interest arise since you completed your conflict of interest disclosure, please let us know. We have to remind everyone at every board meeting in case your circumstances have changed. I also need to remind board members, I don't know how many of you saw the state auditor's report that came out last week, where they looked at 57 boards and commissions across the state. One of their specific findings was that several other boards were not in compliance with board member training requirements. So if any of the board members here were unable to make the February board meeting where we conducted the required statutory board training, please check in with me after the meeting and we can arrange a time to complete that, just so that we can avoid that same kind of water finding. Thank you.
Thank you. Okay, at this time, item F on the meeting agenda is we can go into closed session pursuant to North Carolina General Statute 143-318-11A3 to consult with attorneys in order to preserve the attorney-client privilege concerning matters of litigation, which is evergreen, and to prevent the disclosure of information that is privileged or confidential pursuant to North Carolina General Statute 122C 126.1 or not considered a public record within the meaning of Chapter 132 of the General Statutes.
So moved,
Motion to
Mr.
go
Chairman.
into closed session.
So moved.
Okay. Who's second? All in favor of going to closed session, say aye.
Aye.
Any opposed? All right, we're back in open session. We're back in open session. This is agenda item G, report of the chair, board of directors. Before we get into the two items that we have, I'd like to, everyone may not realize this, but we've mentioned it before, but now officially, our Macon County Commissioner, Ronnie Beal, is president of the North Carolina Association of County Commissioners. He was elected a couple of weeks ago officially. His term started. And it's a lot of heavy load for Ronnie. So if you have any problems with any of your state officers, county officers, call me right now.
For any of the 100 counties with 568 commissioners, just give me a call.
We're very proud of you, Ronnie.
Here I
We look forward to a good year, a lot of good folks involved.
Next item is the CEO evaluation. Nancy Ford's going to talk to us a little bit about the process. Nancy?
Okay, thank you, Mr. Chairman. Every year we do, some of you are very familiar with this. Those of you who are new to the board this year, we do a performance. Those of you who are new to the board this year, we do a annual performance evaluation for our Chief Executive Officer, Brian Ingram. Brian Ingram reports to you, so essentially you are his supervisors and would be the ones to evaluate his job performance over this last fiscal year. I know that some of you are new to the board as of February, and so you have partial knowledge, you don't have the entire year, but we are interested in all the feedback that you have. We have a form that we will be sending out tomorrow morning. I apologize, it was supposed to be in the packet today, and we had a little bit of a communication mix-up while I was on vacation. So we will correct that, and we'll have it to you by close of business tomorrow in your email boxes. What we would ask that you do is that you would evaluate him based on the areas that are identified in the form. We talk about community, we talk about individual, financial, manage his work with you as a board, and talk about his work at the state level as well, so that you can evaluate how you think that he's doing in each of those areas. The evaluations, we ask that you would do them. Please feel free to make comments. All your comments are shared verbatim with Brian during the evaluation process, so that you are aware of that. We do share them. And the...
Basic clarification, those are anonymous shared.
Yes, they are anonymously shared. Thank you. Thank you. We don't put your names on them. Thank you. So those, and actually all of the results are collated. Brian does not see the individual evaluations that you do. Those are all returned to me. And I collate all of that information, and then it will be brought to executive committee at the September meeting for executive committee to review and approve. And then executive committee will make a decision whether the chairman, Rick, and someone else from executive committee, or I've sat in the past, when we actually give the performance evaluation to Brian. Once Brian is presented with the evaluation, then at that point, the executive committee can make recommendations for a salary adjustment, and that would occur at the October board, and a decision would be made. Usually the salary, any salary adjustment would be retro to the start of the fiscal year, so it would be retro to July 1st. We would ask that once we send these evaluations to you, if you could return them to me by September 17th. That gives you a little over 2.5 weeks. I hope enough time for you to do it, but not enough time for it to be lost in your email and get buried by all the million other responsibilities that you have. So we really appreciate your input. We appreciate the time that you will take to evaluate them, and we will report back. Is there anything else I've missed?
No.
Okay.
Thank you, Nancy. Next item is the executive committee report. One item we need to take action on is board approval for the CEO contracting authority. And I'd like to ask our general counsel, Tracy Hayes, to say a few words about that.
So essentially, this is just to ensure, as a new board, that we are in compliance with Chapter 143 of the general statutes, which allows local political subdivisions of the state, their governing boards, to delegate to an individual the authority to award and enter into contracts. And we've prepared a motion based on the recommendation of the executive committee, and I will let Rick read that into the record.
Upon the recommendation of the executive committee, I move that Smoky Mountain LME MCO Board of Directors authorize the Chief Executive Officer to execute and award all contracts within the limits of the annual budget approved by the board, and any amendments thereto for purchases of apparatus, supplies, material, equipment, and services, including but not limited to provider contracts, on behalf of the LME MCO, or the CEO may delegate this function to a member of his executive leadership team in his absence, unless as otherwise required by North Carolina General Statute 143-129. That's the motion. Is there a second?
I'll second.
Okay. Any discussion? All in favor of the motion, say aye.
Aye.
Any opposed? All right, passes unanimously. Thank you.
Thank you. Appreciate the confidence. Guess it's my turn here, huh?
Yes.
Okay. Western Regional Partnership. Before I even get into that, thanks so much for folks that were able to come last Friday to our birthday celebration. It's always nice to throw a party for yourself. And we had no occasion to do that, celebrating our 2-year anniversary being live on the waiver. And it was a great opportunity to just reflect how far we've come. And you know, for a lot of you, you've kind of hopped on the train here after it's already been moving for a while. It's really just staggering to think of what has happened in the last 2 years. And you know, it's kind of a funny way of talking about this. You know, the reality is that we pretty much doubled our size twice in a year and a half. And you know, I don't have an MBA. I didn't go to Harvard. I don't think they generally recommend that as a business process to do, but somehow we managed to do that and did an awful good job at it. You know, because people you know, work so hard and just don't give up. You know, very, very determined group. You know, I reflect on what a great staff we have. The talent's remarkable, and you know, the support from day one when I got here has a lot to do with that. You know, I mean, we really headed in a direction and just didn't stop. And you know, whatever accomplishments we've had, it's been really a combination of forces. So, you know, very grateful for all of that. It was a nice celebration. Nice to have people come and say nice things about you. And hope you enjoyed the videos too. If you didn't see them, tough luck. We're not bringing them out again for a long time. Okay, Western Regional Partnership. I think everybody understands that there's really nothing in the short session on Medicaid. At least for our part of Medicaid. You know, in the budget there were rate reductions in fee-for-service Medicaid. It hit hospitals hard and some others. But in terms of the state's interest, both the governor's office and the General Assembly in reforming Medicaid, let's just say, I didn't get anywhere. There were different bills. I really believe, and I was at the General Assembly in the kind of as they were winding down, and I would just say to you, I think that folks just became so tired and frustrated with one another that they believed getting the budget done was about all anybody was going to shoot for, and once they did that, just wanted to get out of there. And of course, people have to get busy with their campaigns and whatnot. And had anticipated there being a session, a special session in November to deal with, well, coal ash and also Medicaid. And, you know, the information is pretty much unanimously out there at this point is that that's not going to happen. The House was not really in favor of that. Technically, the governor has to ask for a special session. It would probably not be in the best interest of the governor to oppose the House with this. So no one really expects there to be a special session in November to deal with these issues. So the effect on that of regionalization is, in the context of Medicaid modernization and the whole reform of Medicaid, you know, obviously we're a big part of that. One of the elements of that was regionalization. So nothing has happened on that. Nor was there, and there were opportunities for this, they could have stuck something in the budget bill. You know, no legislation, let's say, forcing or introducing a specific plan or timeline around regionalization. One slight mention there was to that was actually in a administrative reduction that all the L&E MCOs have had put to us. It's relatively small, $1.8 million, actually came from the governor's office. I don't know if people realize that. That's the origin of it. And the explanation for it was that it would be as a result of a reduction by, I can't even remember the date now, maybe it's July next year, to 7 MCOs. Now, the way that is written, it does not require that, it just requires that the financial reduction occur. Why it occurs, there's no intent with that, it's just the explanation. Other than that, there's nothing about any kind of forced reduction of the number of MCOs. So, what does that mean? That means we keep doing what we have been doing. And that is to think about things that are smart business decisions, changes that we can make that increase our efficiency and effectiveness. We want to get better at this as quickly as we can. You know, we have never been an organization that was, steadfast about, building it ourselves rather than buying it. And I think we're very flexible around all those kinds of things. So, for example, one of the things we're doing is, and I just signed the agreement just a couple of days ago to provide a call center backup for one another, so that both CenterPoint and partners, when our call centers need someone other than our own staff to answer the phone, say for example when we take people offline for a staff meeting, there's a technical problem, the phone lines are down, for some reason we can't answer the phone within so many rings, we would have that backup in place. It would be provided by either partners or CenterPoint, and the same thing for them. So it's nice to kind of keep this a little closer to home. We've had that arrangement over the years with PVH Cardinal. So we'll be switching that over. It's October 1st, I believe. Correct?
We also next Tuesday.
September. Wow, time's flying. By September, so that everything will be in place for that. And it's in the scope of things that's relatively minor, but it's just a good agreement that we worked out. Another has to do with credentialing, and I've spoken about this regularly. It's the kind of activity that's not real exciting. It's not one of the things that as an MCO we do that we just really love. It can actually, I think this is a good example of something that as you scale it larger, you can actually do a better job. There are just elements around this that as a business practice can be done better than what we're doing now, and I think that's especially the case for the other MCOs. So and this one's October 1st, we'll be in charge of, we will be offering the service for which CenterPoint and partners will be contracting with us to provide for them. So think of this as something that it made more sense for one of the MCOs to do rather than all three, and it can actually be done better. I know somebody asked me, well, is it going to be cheaper? No, it isn't going to be cheaper, not in the beginning. A lot of the thoughts around consolidation in that, you don't realize the savings until a little downstream. There's a lot of upfit and work that has to go into doing this, but at the end, over time, it will become more cost effective. So those areas are two that are reflective of our good working relationship, and other than that, we just kind of continue on with our meetings, our collaboration, and we'll see where the General Assembly goes with this. Any questions? None. Well, at least nobody's falling asleep, so we'll keep going. Okay. Integrated care initiatives. It's a terrible shame Dr. Heck's not here tonight. In fact, I want to kind of maybe not cover things in as much depth as we would if he were here, because he's played such a large role in a lot of our initiatives. We do have handouts. We have, let's see, Integrated Healthcare Delivery System 1300 project. And we have a sheet that's labeled Integrated Healthcare Delivery System, Intellectual Developmental Disability, Comprehensive Medical Home Project, and Regional Advanced Integrated Primary Care Network. And then I believe there's also a third handout about care coordination. We could talk about these a little bit. And this is a topic that we could have a retreat and talk about this. So I guess deciding where to begin and end is a little challenging. The future for what we're doing is clear, I think, regardless of politics or public policy. The notion, if you like the Secretary's language, whole person care, integrated care, that really is the future. And we, as an organization, need to, either through changing what we do or through strategic partnerships, just get a lot better at that. Now, what does that mean? We represent what's considered a carve-out. The aspect of service that we're responsible for has to do with the 3 disability areas and what are thought of as treatment services for folks related to those disability areas, not the healthcare part. Okay? So John Smith that goes to RHA because he has schizophrenia, we are not responsible for his health care. We are only responsible for certain services related to his schizophrenia. That's the simplest way I can put it. That needs to change to a paradigm where we, or some collective we, is responsible for all of what John Smith needs help with. Again, that's not to say that that service needs to be provided by one organization, but it needs to be as seamlessly done as possible. And we need to be able to think about John Smith as a whole person that needs several things done to help him. And I guess it's just the simplest way I can put it. So, when people talk about integrated care or whole person care, it's kind of like, describing the color blue, okay? And I could describe what Chuck Vine's beautiful blue tie looks like. That'd be one thing, and then I could try to explain what my blue tie is, and they're both blue, but they're different. And that's part of the problem with a lot of the discussions around integrated care. There are so many strata, so many different ways to talk about this. I think for our purposes here, how I would like you to think about it is as a paradigm, like John Smith, what I said. We need to really just have a different way of thinking about how we help people. And it's as simple as that. Now, how do we do that? We picked, and there's more on these pieces of paper than probably you would care to know about, but since we had it all packaged up that way, we shared it. Some of the specific projects that we're involved with that really go to how we are supporting all the needs that individuals have. And I can, between Christina and I, we can just try to do a high-level run through of these. In particular, let me start with the integrated healthcare delivery system, what we refer to as the IDD health home. It's very, very novel. And people have asked us, gee, are other folks doing this? What are happening at other MCOs or other hospitals? Christina, correct me if I'm wrong, I don't know of any other place in the state that is actively working on an initiative at this level.
No, not today, of course.
It's very unique, and a lot of what we're going to talk about tonight, and I think this will be a recurring topic, why are we doing these things? How are we able to do these things? A lot of it comes down, I think, to the people and the organizations and the orientation that we take. We have a great partner in Buncombe County, and I know, when I name a county, I run the risk of not mentioning other counties, but, especially in terms of their relationship with Mayheck and Mission Hospital, has been tremendous. And Mandy, I want to, really give you some credit, because I know you're the big driving force behind that. And we've gotten engaged with that as well. So we look for opportunities to do things. And it's really that simple in one hand. And with this, we were aware of a situation with a very specialized physician who is well known across the state for the care that he's provided to individuals and families in the IDD sector for probably a couple of decades. And we started thinking, well, how could we maximize his talent? Where could we place him? How could we engage him in a broader healthcare setting that would kind of drive, again, kind of the John Smith analogy that I talked about. And the perfect home was with Mayheck. So we struck a deal we're in the process of striking a deal, I guess, with them to engage him in a primary care side, and also to work with residents there in just a fantastic program they have. And as I understand it, in fact, they do have a specialty program with IDD. I'll let Christina tell you a little bit more. She's kind of our point person on this one.
Good evening, everyone. Just to add to what Brian said, so we've had this great opportunity. This particular project is very much in development phases, but moving at a rapid pace. The gentleman we're talking with is for you here in this area, Dr. Steve Baker. And so what we are doing with Mayheck and CCWNC here, the Community Care of North Carolina, and many of the spoken staff, we are committed to meet every 2 weeks. Dr. Martin has been a big piece of this and trying to bring the sort of the physician piece together. We have just this week evaluated. Dr. Baker has a current caseload of about 154 consumers that he is currently seeing, and that he has seen for quite some time. If you understand the population of individuals with intellectual developmental disabilities, they have to.
What kind of doctor is he?
He's a psychiatrist.
Okay.
He's a psychiatrist. So, and he does a lot of things, done a lot of things on this system. So we have an opportunity to move him with Mayheck, some additional funding, looking at what it's going to cost us to do this, to actually put him in the primary care piece of Mayheck and kind of sit him in a primary care clinic within the Mayheck system is our goal. And our goal is to have him actually sitting in that clinic between now and January. The sooner, the better. As we do that with him, we are also attaching some great free consultation, really great, coming out of Chapel Hill and the Council of Developmental Disabilities for North Carolina, to make sure that we have the elements of what really means to have an IDD medical health plan. Because a lot of people think, well, I'll just put a psychiatrist in some primary care office and call it integrated care. It is so much more than that. And I think as we go by, you'll continue, as we highlight these things each month, educate you about some of that so you know what it looks like. Because as Brian said, it's different colors of blue, and people are all the time trying to explain it. So we are very, very excited to have a physician who needed to move somewhere else, to take, as Brian said, the opportunity to put him and to really develop a continuity of care for those 154 people. Our ultimate goal is that him and that clinic will serve up to possibly 500 people. We know with the data that we have from Dr. Baker's caseload that we even looked at today in one of our cross-functional teams in Smoky, his caseload is truly beyond Buncombe County. So the consumers in this particular project are beyond Buncombe County, which I think gives us a little bit more taste and feel. And there's 9 primary care physicians that are serving the 154 people today that we would like to provide some better care with. So you're going to continue to hear a lot about this. I think that at some point in time we look forward to showcasing this at a board meeting and really see what good quality care, because many of these people, we know all their medical diagnoses, we know what their medical health profile looks like. We were able to glean a tremendous amount of just really great data for each one of these individual 150-some people. So,
That's great.
Well, the flip side of this is for everyone else. And the irony of this, and we spoke about this earlier, there's more conversation about integrated care for individuals with mental health and substance abuse issues than for IDD. So it's really unique that our first foray here, our first big foray in regards to this has to do with the IDD population. So all that we are learning from this and all those relationships that we are developing for this pilot, you can say the same thing for mental health and substance abuse, which is really just you see the AND Regional Advanced Integrated Primary Care Network. That's kind of the rest of the story. So a great project, and again, we'll talk more about that as it continues to develop. The next one we could talk about, I know I'm throwing a lot at you fast here, and I think we talk about this at a high level, and then maybe next month, let you digest this, and especially with Dr. Heck being here, you come back and talk a little bit more. 1300 project is one that involves Buncombe County, Mission Hospital, ourselves, RHA, and CCNC, and some other partners. Really simple concept. That there are a lot of folks, especially an indigent population, that do not have adequate primary care, nor are they adequately linked to behavioral health services. What an idea, right? So that there could be a very focused process of identification of these folks and a very intensive level of service delivery. And Mandy, I want to give you a chance to talk about it a little bit, because I know the whole genesis of this probably emanates out of Buncombe County. You want to take a stab?
Sure. Buncombe has historically invested in indigent healthcare in an integrated model. Some of that when we contracted out, I can be loud enough, when we contracted out primary care to an FQHC, this year we added additional county dollars to purchase 1,300 discharge slots from inpatient or hospital settings for indigent population in an integrated model, and that's the project that Brian's talking about. It's really a partnership with MAHEC, but MAHEC manages the primary care homes and family care practices that Mission owns, which are 22 practices. So it's much broader than just the individual practices of MAHEC. And the intent countywide is to spread both the expertise and the access for indigent populations across those 22 practices, and to help those physicians and their practices have balance the payer mix, so not everybody is carrying components of it, but it's really spread out. So that's the intent of it.
Mandy, I have a question. Are you finding, and people may be finding it in other parts in the other counties, but when you get to the
Nancy, go ahead and speak up just as loudly as you can, or use the...
Can you hear me? When you get to needing physicians, when you have Medicare and even a secondary, are you finding that a lot of the practices are not taking Medicare patients? I mean, I've called 5 here in Buncombe County, and none of them are accepting Medicare patients, even if you have a secondary insurance. So where are you going to find these primary physicians? I can't even find one. So how are we going to be able to take care of everything that we're talking about when myself as an individual can't get one?
We're actually talking about purchasing the slots for indigent care. That's what Buncombe's investing the money in. We invest about $2.3 million with FQHC and another $300,000 with this new project that's specific to it.
It's a great project. We're very, very excited about it. Both in terms of the service delivery, it's the right thing to do. It's a good thing to do. It just makes sense for people. And the secondary benefit is the relationship. You know, how we're learning to work with, you know, Mayhack and Mission in different ways than we do really now. So again, the lessons, you know, that we learn from this are going to be paying dividends long, long into the future. It's exactly the kind of things we want to be doing. And again, this is, you know, again, back to very consistent conversations, you know, that we've had here. Remember, we're an insurance company with two plans. We've got the Medicaid plan and we've got the uninsured plan. And the relationship between the services that people need for the non-Medicaid folks, the indigent, if you will, the relationship between all those needs and the amount of money is you know, bad direction. Way, way, way more need and people that have need than we have money. So things like this are especially precious. Just can't say enough about it.
Where does this leave, with the ever disappearing three-way beds?
Three-way beds are,
Yeah.
what Ronnie's talking about is a way that psychiatric care, psychiatric inpatient care can be financed. And, you know, Smokey is fortunate enough to be part of a very odd program that the state has that provides funding for indigent care. A certain number of bed days is really the way I think about it, based on an allocation of funds that we have each year. It's way underfunded. Again, it goes to this problem we have with we do not have enough money in that part of our budget to do this. So this is a great help to us. You know, making that program larger would be a great thing, right? That would just help immeasurably. There are not the funds to do this. So again, this type of funding for the three-way beds, as odd as it is, you know, in terms of how it's administered and done, still is a great asset for us. There's just not enough of it. And Mission Hospital, you know, I saw the list of hospitals, Cannon, Mission, you remember the other ones? We were just looking at the list. Rutherford, Pardee, and Haywood are all the hospitals that participate in that. Small number of beds, and again, we could look it up here, because we were just talking about this the other day, but, you know, extremely valuable for us, right?
Anything's better than nothing, because there's nothing now.
Very little.
Brockton, we're not even repeating that nothing. There's nobody referring to Brockton. Out of our ER, nobody's even asking Brockton. They've done to their team provider. Brockton is just, it's off the chart. So if you want anybody that's got medical, you know, it's just, that's a real gap, and if I'm understanding it right, it's to fill that gap. So as soon as you can get it to the rest of the Twin Three counties by next week, it'd be great.
Right on there.
That's
Right on there.
good point, though, Brian. One of the things that you mentioned is some of the things we're talking about now are, you know, in Buncombe County, that Mission Hospital has a fairly far reach in the counties they serve in the small hospitals, plus we have several other hospital systems. So what I think you're saying is when it will have larger implications is that we can use these ideas as models and then begin to try to spread them out to the more rural areas, especially where probably the needs are, you know, as great.
Well, I'm going to let you in on a dirty little secret. There's two big problems we have. Actually, three. One, there are not enough beds in North Carolina. There are not enough inpatient beds in North Carolina, period.
You mean they just got 840, there's not enough beds?
What were you quoting the other day, Craig? 44th out of 50 in the United States?
Right, North Carolina is number 44 out of 50 in availability of state psychiatric beds, which is why so many people are in the emergency department, because there are some beds available in some psychiatric units, but those psychiatric units may not be equipped or willing to take the people we have waiting to be served in our EDs.
It's according to what that fact says when you send that in. We've done it too many times, especially for adolescent beds or any bed. If you put to have violent tendencies, acting up in the ER, forget it.
So we don't have enough beds. By and large, the backup in the EDs is for people waiting for beds, okay? It isn't because somebody isn't doing their job. It's because there are not beds for people to go to. Number two thing is, there's not enough money for indigent care. Could we be doing more for people that don't have insurance on an outpatient basis? Or could we be doing more in terms of placing them in inpatient settings if we had the money? Yes. Okay, so those are the two things right there that would change this tomorrow, okay, if either or both of those things happen. The third thing that is just a kick in the pants is you talk about Broughton. I believe it's 30% of their beds currently are occupied by individuals that are classified as unable to proceed. They have been involved in the criminal justice system and had a forensic review and have been deemed incapable to some degree of essentially understanding their circumstances so that they cannot be prosecuted in a criminal justice setting and need to be in a psychiatric setting. And they end up, I'm going to just say, more or less in limbo. Very difficult population of folks to then get discharged. It's cumbersome. So many of the beds are taken up by these individuals. It is not to say that they don't need care. Please, it's not that. But, you know, this blending of criminal justice and mental illness and all of this is just reflective of we do not have the infrastructure in terms of beds to deal with all that is getting thrown at, in this case, the hospitals, you know, the EDs. And that's it in a nutshell. Kind of went off on a tangent. So, you know, if anybody asks you what's wrong, you can tell them those three things, okay? You'll be right.
To give you a clue where we're at, there's one in Clay County, I'm sure Rhonda knows about it. Today's her 8th day in the ER. 8th day, today's the 8th day.
Waiting for a bed.
Yep. So
In an unknown place.
she's almost to the record. She's getting close. The record's 12. So she's right there at it. This lady needs medical, psychiatric work. I make that, put that in your dictionary. So, but it's just, you know, so, we've tried to help them, and nobody would, not even we can consider.
Let me change the scope a little bit. Strategically, you know, as an organization, you know, where we are headed is to align ourselves as much as possible with healthcare. And I think we have some real advantages in this neck of the woods, and again, it comes down to individuals, it comes down to organizations, it comes down to state borders, it comes down to mountains. You know, we do have a defined healthcare region in my view. And you know, my job and our job is to maximize the synergy of those relationships. Again, going back to the kind of the John Smith story, that you know, we can use our relationships with healthcare to get everything John Smith needs, or John Doe, or whomever it might be. And as we go along, I hope we'll be talking more and more about that. We have, you know, we have a real advantage, I think, in terms of the relationships and the organizations we work with. This is not the case in other parts of the state. So, care coordination is the probably the biggest interface that we have. And Rhonda is always fond of pointing out the federal definition of care coordination. So I'm sure she will this evening, about how our responsibility is to care for, again, all of John Smith's needs, right?
Yes, yes.
That's right. So don't get trapped into thinking that when we're talking about care coordination, we're really only dealing with behavioral health or the IDD elements. Now, is that probably the lion's share of what we do? It's probably fair to say that it is, but it's not all of what we do. So this is just an emerging part of Smoky that is working, again, very much in this world that we're embracing, and wanted to give Rhonda a chance to just, again, educate people a little bit more about care coordination and how that interface works.
We can't hear you.
I know, and when he hands me this, I'm gonna feel the need to karaoke or something.
Yeah. Oh, dear God.
And you're gonna join me, right? So, you have the document, I'm not gonna read it all to you, and as Brian mentioned, I am fond of pointing out the federal definition, because I think there's a lot of confusion sometimes about the old world of case management and what administrative care coordination is. And so there's a lot of education that continues to need to be done in our system relative to what administrative care coordination is and how that really does look at a person from a holistic care perspective. And I think the other thing, the variations of what integrated care is, integrated care inside of Smoky deals not only with the behavioral health, the medical and dental side, but for many of you who are stakeholders as a social service agency, a juvenile justice rep, or those types of things, we also are responsible for integrating care across all of those areas. And so taking an individual, when they first come, if they are eligible for care coordination, again, not everybody in the world is eligible for care coordination. Those are the most acute individuals that we serve, both with intellectual and developmental disabilities, as well as mental health, either substance use. There's sort of that top level of person that we manage in acuity. And then we work to try to ensure that all the partners involved in the care are there, part of the planning process, and that we're not doing a lot of redundant function and people getting lost in the system. And if any of you have ever had to navigate a loved one across any kind of healthcare, you can appreciate what that takes. So you're going to see some key areas. Again, these are the federal definitions, items 1 through 5. I'm not going to read them all to you, but what I want you to be aware of is, because of our team structure, we have hired RNs. We do address individuals. There's 2 categories where someone is actually assigned to an RN care coordinator. If someone is medically complex, there's a series of things that are going on in terms of many medications, multiple health issues, as well as psychiatric diagnosis. They will actually be carried on an RN caseload, specifically to address those higher acute care needs. However, all care coordinators have access to getting consultation from an RN, because we know that the bulk of individuals that we serve have high-end healthcare issues, but they may be managed or maintained through medication, or if the person would take their medication, they could be stabilized on the healthcare side. Likewise, on the intellectual and developmental disability side, we have something called medically fragile. And again, this is an individual that has either a particular physical disability or cognitive disability that qualifies for IDD.
What kind of disability?
Physical or cognitive. So you could have cerebral palsy and qualify, but you could also have a low IQ. You can do that at the same. And again,
You could, with a low IQ, you could qualify for medically fragile.
and really complex medical issues on top of that. And so what we've done is there's a threshold that we developed with our psychiatric team and some medical specialists around what makes sense. Mercer actually gave us some feedback, our national consulting group, about that as well. And again, all of this is around when a person comes into care coordination, assessing them holistically. Now, we're not doing what Duncan's job is, where as a provider, they do a comprehensive clinical assessment, but we're looking at him across the board to say, what is it that this person needs? And then formulating a plan with their team across multiple systems. And working with them to, if they're in mental health or substance use, till they're stable. If it's an innovations consumer, we are with them for the long haul. And really trying to...
What is that?
In some cases, it's lifetime.
Oh, I have a
An
question.
innovation, you said?
Yes. If they're on, that's the other waiver. So yeah, we have 2 waivers.
For people with intellectual or developmental disabilities, right, that's the innovations waiver.
I've just been here 10 years, I still not got caught on all the acronyms.
You're just testing.
I have a question. You're talking about the most, that's gonna need the most help, and I know of several incidences where we have people who have these kind of IDD in their home. And I understand what Smokey is trying to do. My question is, how are you going to end up with care coordinators trying to get the plan put together? And I know there's some awesome plans out there because I have one for my son. But if you don't have providers that can give you the backup staffing to take care of these, and because these families require that, and they get the letter from their provider saying, sorry, Charlie, I can't give you backup staffing, I'm dropping you and you're gone, what are you going to do? Because I haven't heard an answer to that, and I've been listening to that for 3 months, and I know that that's happening. So how do we fix it?
I think it's valid. Backup staffing has been one of the largest kind of internal performance issues we've been dealing with around service providers on the IDD service side. We see it even with our large-scale, sort of very person-centered organizations in that, and we work with them. The way we were trying to address it in the most severe cases is with specialized rates, some of the performance monitoring, the requirements around the technical assistance. What we've seen, though, is it's not been enough yet. And we continue to battle, and it's typically with the more complex cases we really see that. And I agree with you, Nancy. It's been a long-standing issue that we've been aggressively working with our large-scale providers to do. I don't feel like we're at the place yet where we have a satisfactory answer in that.
I don't either.
Consumers.
When they drop the people that they're supposed to care for because they're not going to provide the backup staffing, and this is one of your major providers, you know, it gets we as parents in a very awkward position, because I have enough sense to know that if I push Monarch hard enough to get what I need for Jerry, I could receive that same letter in the mail telling me I'm 30 days, he has to be out of their home. Well, where am I going to put him? So my hands are tied. I have very limited say into what I need to have done. And other parents have no say because they're going to get dropped. They're going to get that same letter. And something's got to be done.
And I think you're actually highlighting one of the other areas where care coordination does play a part. About 48% of quality of care or complaints come in around service system issues actually come through the care coordination door around service-related issues. We are the largest reporting entity of all the complaints that come in the entire agency, both internally and externally. We are the eyes and ears that kind of bring that forward so that they can get divvied out to, whether it's the network and monitoring and dealing with that particular issue, or if it's some other type of issue in that. So I think that's a piece that I know for us, that's how we manage that, so that the other departments that actually have a role for fixing it can do what they need to do and actually have the documentation that's available with it. I think the other piece that's key, and I want to be mindful that I'm between you guys and dinner, and there's more agenda items than just me, is we have a lot with treatment planning and referral and linkage. We also, like CCNC, are responsible for looking at people at the individual level, sort of risks to themselves and their ability to function at their highest level, at the most independent level, but also understanding that people with schizophrenia have certain kinds of issues and needs, both from the medical side as well as behavioral health side, and working both with the local folks to say, how do we help Jerry or whoever, or John Smith, and then on the other side of that, as a system, coming back to the network to say, how do we develop gaps in care? So all of that sounds really wonderful, but how does that play out in real life? So I got an email, as I often do, from my fearless leader at 5 o'clock yesterday. And he said, you know, can you give some real live examples of how this really works? And so I just want to give 2 brief stories because I think this highlights it. And I'm not going to say anything here that sounds magical or over the top, but it's just kind of the balance that shows how do you take care of people. In one instance, we have a lady that has been in a sort of community treatment team services, so our highest level of community-based services, and walked into one of our regional offices, and she said, I think I'm having a panic attack. And so my clinical staff was there, and they started getting a little bit more information and about it, and it sounded a little bit off. So this wasn't her coming and bringing this to an RN. This was just the licensed therapist in the office. And she says, yeah, every morning at about 10 o'clock, I'm starting to feel like I'm about to fall apart. Well, basic education, the question came, do you have diabetes? Well, yeah. Have you had any recent changes in your medication? Well, they changed her heart medicine 2 days ago. So they took her to the, she went and got her scheduled with her doctor's appointment. Sure enough, blood sugar was out of whack. Very, very simple fix. But so often, we don't ask the question about these other issues. It was as simple as just getting a checkup. Sure enough, she did. She got stabilized, made the ACT team aware of this very brief intervention and follow-up. They were able to work with her about making sure that she didn't miss her medication. She's stabilized. We haven't hit her with another psychiatric medication to address her anxiety, and we actually solved the problem, and she's doing really well. The other scenario that we had pretty recently is we had a gentleman who was assigned to a mental health SA or a substance use care coordinator, is also an RN, individual who has probably burned through every bridge he has a traumatic brain injury, has hepatitis, has a whole range of other health-related issues, and a heavy-duty substance use history, and a very active user. How many of you who deal with EDs know this person? I mean, I'm not saying you know this particular person, but you know the scenario, right? Very, very difficult person to trace. In this scenario, I think once we got the medical issues stabilized, that part was okay, but his substance use was throwing everything else off. So if you don't take care of his treatment needs, he's not going to be very stable when it comes to all these other significant health issues. And where is he going to spend his day? With any luck, he'll go to Angel Hospital. Or somewhere. He'll end up in Mission ED, one of our local EDs. You know, they were able to get him stabilized, got his health issues stabilized, managed that, got him connected with treatment, actually got him, he came into the care coordinator within 24 hours. They had him inside of Neil Dobbins' unit. He stayed in Neil Dobbins, he completed his course of treatment. He went to a recovery group, he stayed with his recovery group. This person has now transitioned from a very high level of supportive care to living independently in his own apartment. It is the longest period of sobriety he has ever had, and his family members cannot believe that this is the same person. And again, this isn't rocket science. This was working across multiple systems, talking about what this individual's needs were, and everybody sort of saying, I've got this piece of the plan, and then someone walking beside that person until they actually got through it. So we see this every day, whether it's with a child in a complicated case stepping out from a PRTF back home, or if it's with the family unit. Again, it's the whole person, and often it's the whole family if it's a kid or an adolescent. So, say integrated care right now is a heavy buzzword. I think it's smart, it's good practice. I think it's something that we definitely support, and we are really pushing our internal teams to manage and support care across the system. That's our role, responsibility, and so I think, again, we just want to highlight, it's not always, like Christina said, it's not just putting somebody, like a therapist in the middle of a medical office. It's really about walking the person through the system.
One of the things I would just like to say, it's been such a pleasure hearing some of these success stories that London has been sharing recently with your foundation. But one of the things we're doing through my department is we are working with Rhonda and the care coordination staff. And we're going to begin doing success stories and highlighting some of these activities, because we oftentimes hear about what goes wrong, and that's just the natural way things work. But we want people in our communities to start hearing about all of the good work that we're doing, because things like care coordination and the function of care coordination is what separates us from a private organization. So you will soon, we're just one step away from beginning to highlight the success stories that are going on in our organization.
Thank you. It's not cheap either, doing all of this, what we do, but we're gonna keep doing it as long as we can. Skipped over number 2 here, relocation of Asheville office. We've been talking about this the last couple of months anyway. There are much better purposes of use for our offices on Biltmore Avenue. We're always recognize that, and it's been just a matter of how quickly could we kind of get our act together to get out of there and find another place and think about our workforce and as we mature, who needs an office, where do they need to go to work every day, all of that. To make a long story short, we're progressing on our plan to move to Ridgefield, which is an area down Brevard Road. If you're familiar with where they're building the new outlet mall, I guess where the old Kmart used to be in there. What was the name of the mall? The Biltmore Square Mall for folks that are local. It's back behind there. It's really a business park. And with any luck, we'll be able to locate ourselves there, I'm saying in the spring. So we'll see what month of the spring, depending, I guess, on the construction schedule. And we'll have a resolution tonight that's in relationship to that I guess we'll probably take up under Finance Committee. We're very excited to already be working with the county that is the owner of that office space in Biltmore, Mission Hospital, and other community partners, and especially RHA on the repurposing of that site, which could be a great asset to our service continuum, especially around crisis intervention. Having both a bedded program there as well as a outpatient treatment center where we could really do so much more than what we can presently do with services that are actually quite limited just because of the physical location that some are in. So you'll hear more about that as we go forward. And I think we actually covered Vantage Point. That was a nice segue, Rhonda, you did in terms of the integrated care conversation. And I feel, it's such a great topic. We've only touched it tonight. We're going to be hearing more and more about this. I guess I can hand this over to either Judy, you and Fred can play catch with the microphone, or give it to Fred.
Turn it up.
Okay.
Explain the two resolutions and what we're going to do.
Okay, thank you.
Okay. I will do this in two parts. One, simply to briefly go through the financials because those things to be separate. And second, to go through two resolutions. I will not go through each and every sheet, just some of the highlights. The first sheet, which is pink, is the balance sheet. It is a unaudited, consolidated balance sheet for both Western Highlands and Smoky. The audit is in process. Hopefully in October it will be complete. We will see. They're coming again on Tuesday, so we'll see how close we get. Cash in an impress account comes to about $85 million. The risk reserve is now up to 12.5, thereabouts. To talk about current ratios, this is current assets over current liabilities. Medicaid only is 2.7, and for all sources, it's 3.1. That's quite healthy. I will focus a little bit on the accounts receivable Medicaid waiver. You're not used to seeing that. The reason you're not used to seeing that is we have a new phenomenon. Our PMPM pays us by category.
Your what?
Excuse me?
Your what pay?
Well, hold on.
PMPM?
The PMPM. Per member,
That
per month.
109 or what? What is that?
Per member per month. I was going to get into that. And that is per Medicaid enrollee for the 23 counties that we are responsible for by categories of age. We actually get a payment for each enrollee in the Medicaid program. Well, that sounds good. Our risk is to provide services to those who are eligible for behavioral health services on the IBD, mental health, and substance abuse side. Within that Medicaid eligibility groups, to provide services to them with those funds supplied by the PMPM. Okay. Well, what if the eligibility group doesn't match with what we're being reimbursed? As we have checked, there is a discrepancy. We are being shorted. That discrepancy is statewide. For us, as of June 30th, it is approximately $6.2 million. Statewide, by June 30th, it's just under $50 million for all of the LMEs, MCOs.
Is that for a year or cumulative for?
That is not everything. Let me
Okay.
get into that. That is what is known. The reason for part of it is we do not know for the first quarter of FY14, July, August, and September, what we are truly owed. And the reason, because of NC tracks and all the difficulties that people have heard about NC tracks, we cannot reconcile that first quarter. So indeed, what I'm talking about as far as the shortfall is from October 1st to June 30th. Only. What we've done here in terms of the $3.1 million represented is net. It is taking a full accounts receivable, allowing for a 50% allowance for doubtful accounts, and that is the net difference. Now, in my heart, do I expect that we will collect what we are due? Yes. Reason for that is both the Division of Mental Health and DMA, the medical assistants, has acknowledged that there is a problem. They have acknowledged that they owe us something. What's not clear is the process for resolution. Reason I have a bet that I hope I will lose in terms of when we will actually see those dollars flow. But I do feel that that accounts receivable will be collectible. But until then, you will increasingly see this, and you will see this dollar amount grow. Now, what we have been told and received correspondence from the Director of the Division of Mental Health is that a resolution will start flowing in the month of September. For a number of reasons, I would not hold my breath. But that's what we have been told.
Fred, is it, or Brian, really, is it just as likely that you'll agree to a settlement and that it's reduced next year's PMPM to compensate for it?
Actually, it is unlikely.
Really?
The reason for that is we have entered a legal contract. That legal contract is premised on what we will be reimbursed for the risk that we are incurring. Those terms are rather clear. So they would be breaking the contract, and indeed, us and all the other LMEs would have grounds to go to court should they decide to break that particular provision, more than likely. Now, would they try? I don't know. We'll see.
When does the contract expire, the current contract you're talking about?
Excuse me?
The current contract is
June 30th.
June 30th? And then there's a new contract?
Yeah.
Yeah.
More of what will happen, Carl, the more of the conflict or the rub will come in around disagreement. I mean, let me make this really simple. Fred gave a great explanation of our per member per month. So we got 157,000 people that we received some money for, okay? We're not getting paid for all of them.
Right.
It can't be reconciled. It's like having a checking account and you can't go to the bank and they tell you what your balance is. That's really that's how bad it is. We're keeping our checkbook going with what we think is right, but we can't go to the bank and get it straightened out. So at the end of the day, that bank, in this case the state, is going to have to come clean on that and say, well, no, here's what your balance should be according to what we got. Where we're going to have the trouble is that day when we try to reconcile with their explanation of it versus ours.
And I agree with you 100%, but I wouldn't go out and spend that money for fear.
No, we're not.
Here.
Hey, listen,
Yeah.
what, the good news about this is that we're not scheduling bake sales and car washes. Ed doesn't have to stay the weekend and go out there and wash cars. Okay? You know, we're not so tight financially. He didn't even laugh at that. He's funny. He's a deep thought. We're not in such a tight financial situation that $6 million is killing us, okay? We sure want to get it because it's due, but we can manage with that.
The bigger issue is if there's clients in the retention meeting who need services that we know we can't provide because we don't have the money.
Here's the back way that this really hurts, is we have individuals who are not believed to be eligible for Medicaid services, okay, that we're having to fund with state services, and you hear my sermon about every month around, you know, here's the need up here, here's the money down here for that population of people. If we knew that that person had Medicaid, we got a lot bigger field to play in financially. That's where it's really a bad thing, is we're paying for services with state funds that we could be paying for Medicaid because the eligibility is screwed up. And all you DSS folks know all about that, okay? He's gonna have a stroke down here probably if we keep going on that. So that's just another feature of this that on the client level, you know, is a bad thing.
Brian, if you notice, Fred is saying $6 million, and if you look in your report, they're only accounting for $3 million. He's not expecting $6 million to come back.
Well, we're taking a conservative approach, and the reason is, I say this, you have to stake out that you owe this money, but you also don't want to misrepresent that cash is readily available. There's this thing in accounting called aging of accounts receivable. Well, you can distort that by saying, yes, I feel that the $2.2 million is owed to us now. How would you feel if that money was on the books for 6 months, for 8 months, for 9 months? The collectability starts to become an issue. It's a safer thing to state that there is an allowance against that rather than stating the entire amount. It's overly conservative on my part, but I think it's a more honest presentation in terms of how our business operates, which is on cash. We get a payment, we have to pay the claims that come to us. That's the reality of the day-to-day operations of what we do. So it's representing what we are owed, being honest about it, that it's there, but realizing on a day-to-day basis, we have to pay the bills.
I don't think you're being over-concerned.
I agree.
Brian, if these people that are eligible, if they ever get straightened out and they get their Medicaid, would or will it go retro back to where you would be able to get the money back in and then be able to move the money back over to the state funding, or are we always going to be playing catch up and we're never going to get what when they become eligible? Is it ever going to get balanced back out?
Great question.
Partial answer, because they could fully satisfy you. In terms of Medicaid, it will go back to their date of eligibility. That is true. Now, when you talk about if other funds were expended at the time for that individual, will those funds be, quote, replenished? It depends on which accounting period you're talking about. So, for example, if it occurred in FY15 and it was an FY15 expenditure, would it? Probably. If we're talking about FY13, going back that far, would it? Forget about it. That's history.
It's a very, I mean, you just think about this, like this bank explanation, that's pretty good, okay? Now, you know, you're talking about going into a level of detail, you know, way beyond just knowing how much money is in the bank, how much is in your account. I mean, it becomes more and more complicated with doing the retroactive stuff, because you got to know exactly the person, exactly the date, what was done. It just gets more and more difficult and less likely to be accurate, basically. Yeah, there's nothing that's gonna be said, the more we talk about it, it's just gonna get worse, so we should probably stop.
Moving on, because I know we can talk about it just that today. Going further down on the asset sheet, since we own very minimal property, you'll notice that the major asset is in the form of computer equipment. Just making you stated. Going down to liabilities in terms of payables, for those who may not know, the accounts payable, IBNR, those are claims that are outstanding that are not in our hands yet. We know they're out there, we know the service has been provided, these are claims that are pending that we know we have a liability to pay. Going to the fund balance sheet, there is a resolution that affects 5 of these lines on the balance sheet. So I will come back to those later. I will just highlight 2 or 3 of them right now. One is the Medicaid risk reserve that is here at $12.5 million. The other is to go down to unassigned current year under Medicaid, that's $15.7 million. That is indeed revenue over expense on the Medicaid program that we have earned in FY14. So that's revenue over expense for FY14, both on the service end and on the administrative side. Other sources, the next line, current year, that is on state and federal and other sources. We have revenue over expenses on the order of let's call it $2.6 million in those lines. The next sheet, which I will not get into, details it by service category, dividing it between Medicaid and state and other local funds, a detailed description of each. The next page talks about Medicaid budgets and actual in FY14. While we overall come out with a surplus, there is certain areas that we are monitoring on an ongoing basis and we are aware of and have to watch closely during the next year. Talking specifically about Medicaid, B3 services, while that level of expenditure has increased during the course of the year, given the narrow parameters on the expenditure of funds for those services, it is still an area that we need to work on to appropriately utilize. I will not get into the demographics that much, except to talk about the current asset ratios, which is the second sheet of graphs that you have here, which demonstrates that the current ratio on the Medicaid side is 2.3 and on all funds at 3.1. Both of those are good, accurate measures. The general watchword is we have to stay over a 1-to-1 ratio. We get into trouble if we go to that or below for 3 months or longer. I'll say not on the door in reference to your partners at the traditionals if that ever happens. And the rest I will leave as is unless there is any questions. Okay. We will go back to the balance sheet. There are 2 resolutions. And with Judy's permission, I will go through them. One resolution affects 3 lines directly associated with the increase in the FTE count at Smoke. Meaning we have more employees. When you have more employees, there's a certain set-asides that need to be increased. Specifically here, we're talking about unemployment compensation, annual leave payout, and retention risk pool. So one motion, one resolution, covers an increased allocation of unemployment compensation from $250,000 to $500,000. Again, that's to account for the increased headcount. The second is an increase in allocation for annual leave payout from $325,000 to $1.2 million. That is an actual number. If today we had to pay out all the employees for what's accrued on the book that they are owed for vacation benefits, this is what we would have to pay out. An increased allocation for retention risk reserve, doubling that again from $500,000 to $1 million. So the resolution is rather wordy. What it boils down is an increase in those three accounts, those three allocations. Now, where does it come from? Literally speaking, when you're looking at the balance sheet, it comes from unassigned. So you're moving balance from the unassigned account on this undersigned allocation to the committed on those three lines. So that's the motion.
Okay, is there a motion on the floor to accept that resolution?
Mr. Chairman, I make a motion to increase the unemployment compensation from $250,000 to $500,000. Annual leave from $325,000 to $1,200,000. And motion for retention risk pool from $500,000 to $1 million.
Second.
We have a motion and a second. Any more discussion? If not, all in favor say aye. Okay.
I'd like to make a statement. For all the board members doing the finance committee, that this is the unanimous request from the finance committee. We approve this resolution.
Any other questions or comments about the motion? Okay. All in favor say aye. Aye. Any opposed? Okay, it's unanimous. Go Fred.
Okay, the second resolution has to do with Bridgefield for another alternative administrative relocation site. That affects two lines on the committed part of the fund balance, specifically administrative offices, which is listed at $1,957,000. The other is Medicaid waiver readiness, which is listed at $1.6 million. The purpose of the resolution is to combine those two lines to allow, well, it's the board's authorization to allow the use of those funds for leasehold improvements as well as equipment purchases for an alternate administrative site, specifically for Ridgefield, should that not work out, for an alternate administrative relocation site. Now, what is leasehold improvements? Leasehold improvements would include the data lines, it would include the telephone wiring, it would include the HVAC system, it would include security for the building itself, it would include carpeting, it would include painting, it would include dividers, it would include new walls, it would include new lighting, it would include sound dampening material, anything that's required for our use of the space to make it a workable. Equipment is the acknowledgement that some of those things would be equipment purchases that are being to us in order to make work. Now, do I anticipate that we would use $3.5 million to do all of that? I do not. Two strategies. One is the fact that it's always better to ask for funds, because this has to be approved by the Division of Mental Health, and not have to ask again, so you always want to ask for what you a little more than you need, simply so you don't have to be put in a position to ask again. But the other is to raise this for our future use, should we use to do so for other capital purposes in the future. So it's to reassign those funds, park those.
How long is the lease?
5 years.
We're going for us to lie?
I was going to say, that's an awful lot of money that we're investing in something that we don't own. Are they going to be, whoever owns this, are they going to be doing it?
Let's talk about the realities of modern commercial space. In the space that we...
How many do you own? I just got 24 of them.
Hold on, let me go on. In the space that we're currently using at Biltmore, we are paying $15.90 per square foot. Okay? For 42,000 square feet. Our monthly payments right now are $56,761. So our annual payments are $681,000 for a space we do not own. For a municipality, okay, this is municipal space. For the space that we are going to, Our square footage expense will be $13.98 for the first year, and our payments annually will be $450,000. So there will be a savings in the move of $130,000. Yes, this will be a lease. Yes, we will not own it, and yes, it will be less expensive than what we're currently using
For 5 years.
for 5 years.
Not on the buildings, no, I know that.
Let's talk in an idealistic sense of the word about being able to predict the future. 3 years ago, we would not have predicted that Smoky would look the way it does now, with the configuration that it has. I cannot predict 3 years from now what Smoky will look like in the configuration it would have. It would be unwise to make a significant financial investment that new construction would be, or the outright purchase of a property would be, without clarity about what the future looks like. I can't predict what it will look like in a year, no less. 3. Now, financially, would it make sense for Smoky to make that kind of investment? Probably. But we're in a political world that looks like, a fishbowl. And I don't think that's politically supported.
The county owns the building?
No, not in Richfield?
Yeah.
No, that's a private development group. There's a bunch of people, involved with that.
Different
We
buildings
deal
have
with
different landlords.
We deal with their, manager.
Different buildings, people own different buildings, yeah.
I think it's the whole group owned, it's a large business park, Ronnie.
I don't know though.
Yeah, I don't know how many different investors there are and members in the company.
Two questions. Does the 1398 square foot include the CAM? The community, you pay, we have offices there. So you pay in addition to the 1398, a community maintenance kind of fee.
That is included in that.
That is included in that. And then is there a significant increase year over year for the 5 years, or is it pretty flat?
As is the case with our current location, there is an escalated provision. In this case, it's 2.5%.
Okay.
Currently, at Biltmore, it's 3%.
Rental business space in Asheville is terrible.
Move.
Yeah.
We got a building.
We got bedrooms still.
Yeah, well, that would create other problems.
You've got
What it
lots
is.
of people and stuff.
Yeah.
Is there any more questions? Got other items on the agenda? Is there a motion? We got a question?
Quick question, has the finance office, did the finance committee review this and make a recommendation? That's what I haven't heard yet.
Yes,
Thank you.
I didn't say that at first, and Chuck brought it up. Finance committee, we did sit and go through this and met today, and we agreed with both of these resolutions.
Sharon, so the,
Okay. We have a motion. Is there a second?
Second.
Any more discussion?
Who wrote the lease? Who's got the lease?
Tracy is currently reviewing it.
So we don't have a lease?
We haven't signed it yet. We have a draft, yes.
They give you the draft?
Yes, sir. We have,
Yeah, you're going over it.
we do have a signed agreement to lease, but we have not entered into the formal lease. The agreement to lease does include a standard availability of funds clause related to our status as a local government entity.
It's got an availability of funds clause.
oh, that's good.
Okay, we have
think everything.
a motion and a second. All the questions answered. All in favor say aye.
Aye.
Any opposed? Okay, it's unanimous. Okay. Thank you, Fred. Next item, Consumer and Family Advisory Committee report. Pat? Yes.
I'm real thrilled that Nancy and I and Judy, which would have been all three of our board members, were able to attend the waiver celebration. In addition to that, we had at least 2 other CPAC members that were able to attend that. We had local meetings in July, and I guess one of the reasons I'm gonna focus on them, we had a little bit of a tizzy after the local meetings. Some folks' mileage checks bounced after those local meetings, so some folks, I think it's been straightened out, but we're a little bit upset about it, and I just kind of wanted to mention it because Jerry says he wants to hear the details. So that's some details, Jerry. We had a joint video meeting on August the 19th. It was hosted by the Southern Region, and Nancy Baker led it. Our annual retreat for CFAC is planned for September the 12th and 13th in Asheville with the following proposed items: my story, provider monitoring, program integrity, gap analysis and needs assessment overview and disability-specific breakouts, and the network development plan. Smoky CFAC members are also pleased to continue to be involved in a variety of committees, all the way to the board level committees. And we serve on a variety of different committees in our local areas, as well as some statewide, and other people are even participating or have involvement at a national level. Our members and the community at large have been coming together to enjoy the opportunity to participate in trainings that Smoky has opened up to them, and I would like to invite the guests to look at Smoky's website and look at the trainings, and also if they're any interested, please let someone know and join us in some of these trainings that have been opened up to the public and board members too. There's a lot of conferences and trainings happening in the next couple of months that our members have been given information on. A couple that I've recently been given information on are the annual recovery conference, of which I'm proud to say Smoky is going to be one of the sponsors. Another would be the substance abuse conference. It's going to be held later on this year in Morganton. Those folks, I went to one of theirs several years ago, put on a good conference. One of the things I'm most proud of at our last meeting, back when we had our local meetings, we were sitting there talking, and we've had a couple of members that, due to health problems and other issues, have not been able to attend. So one of our members that's living arrangements had changed was back at our meeting last month, and another one who's had a broke leg and several surgeries was able to participate. We made reasonable accommodations as part of our last CFAC, and I'm proud of this. One of our members who's been out for several months with a broke leg, we realized that we could allow her to participate by telephone, and she was delighted, and we were delighted that she was back with us, as well as the other one that's has a new living arrangement that was able to come. CFAC appreciates the opportunity to give input, the continued inclusion that Smoky has allowed us, and we were the featured LME MCO of the last state, one of the featured LME MCOs of the last state to local CFAC conference call. And they were told, and I told them this, that as far as I was concerned, Smoky had the best working CFAC in the state, and I thought it had the makings to be a good national model that, you know, I hope someday to see national CFACs. The only other complaint that I heard at our last CFAC meeting, other than the mileage checks, was one client came to me after the meeting, or CFAC member, and said, you know, I have to be drug tested to get certain medications 30 miles up the road. They're handing these medications out without drug testing. Well, for me, I don't think drug test is a big deal. If you're doing everything you're supposed to be and you're trying to be recovered, then you have nothing to worry about when it comes to a drug test. But she did say to me, I'm going to file complaints and I'm going to file grievances. So it is not the same all over all of the different areas. Some providers in some areas do it one way and some areas do it another way. And, you know, folks are talking about this and realizing it's done different in different parts of our catchment area. As far as our retreat, any of the Smoky board staff that would like to come join us, please contact Brian Shupin. Staff members too, we all want to work with you as a team, and we welcome you and your input. Special day was one more thing that folks from Smoky got to, from the Consumer Relations Department, attended in Marion. I attended, there were more than 600 clients. Even Joyce from Caldwell County, one of her workers came and was going to bring 2 clients, but brought 1. So I think Special Day was a success, and it was good to see Smoky staff there. Thank you.
Yes, ma'am.
I'd just like to say how proud I am of Pat. I mean, a couple of years ago, Pat came to this board and she was afraid to even speak. And I think she has done great, and I'm proud of her. Fred says I have to give the microphone back to him now.
Pat related an incident that's rather embarrassing, and that is bouncing checks. Of course, no one wants to hear that. An apology has been extended to all CPAC members that were extended. There was an error made in an electronic transfer that did not show up at the bank. We did not know about it until the following weekend, at which time and location was sent to the CPAC members who were affected. All payments, as well as any penalties or fines, as well as payments will be paid. Again, my apologies to both Pat and to the CPAC members that were affected. I would like to say that Cigna is perfect. It is not. There's always some errors in every system, and unfortunately, it affected those who really support it. So I do apologize.
I didn't believe it when I first heard it. I thought it was somebody trying to scam Smokey. I said, no.
Provider Advisory Council report, Dr. Sumter.
Thanks, Mr. Chairman. The Provider Advisory Committee continues to enjoy a positive relationship with Smokey that's built on transparency and sharing information. It's just a good place to be and working together for all the challenges that we've heard about this evening. So there are some positives going on. A couple of things to report around the Provider Advisory Council. One is a new subcommittee has been formulated as on integrated care. We've heard a lot about that from the Smokey staff today. It's a very important initiative, and providers just like the state and the LDMCOs are trying to figure out exactly what that means and how can we do that in a way that really provides good results. Another one that I talked about last time is really getting some legs, and that's the Licensed Independent Practitioner Subcommittee. This is a subcommittee for independent practitioners who are not a part of the organization, but certainly are affected by all the changes in our transition. Sean Jones is working with them, and I think meeting on Saturdays probably, because those folks just report to me during work hours very easily. So again, a good working relationship is really important. We feel like we have that right now. There are a lot of challenges and hurdles to overcome. We're just glad we will work together.
Thank you. Our next report is report of the Performance and Quality Committee. I call on Carl. I don't think we probably need a microphone, Carl. That's just a loud yes.
Thank you, Rick. I appreciate that. We had a good meeting today, and appreciate Pat being there, and Duncan, and our newest member, Mike Lavender, who represents the County Commissioners Committee. He jumped right in. We continue to try and go through a number of different reports that are provided by the staff and developed that are given to the state. And what happens is we start looking at these reports and these numbers, and the first thing that happens is we start talking about services and service delivery. And it's a difficult challenge if you listen to the group that's on there to just stay and look at numbers, because the numbers don't tell the story of the real service provided. They're indicative, but they don't tell. But we had a good discussion. We appreciate Julie and Tommy and really just giving us more information to try and drill down on what is the real service and what's the real issue. So it's tough. This is new for all of us. So do appreciate that. One comment that we did discuss is that a lot of our data that we're comparing is statewide data. We establish statewide standards based upon statewide averages. But for those of you who represent rural counties, that can be very frustrating because it's hard to compare our rural situation with the urban counties. And so the same applies to a rural-based MCO compared to an urban-based MCO. The comment we made to Julie was, as you can look at this, don't try and always compare us statewide, because it's always good to try and be better than we are. But for example, response times, we may not be as quick because we're spread out over a third of the state, and rather than just 2 counties or 3 counties. So happy to ask if the other committee members want to mention anything, but we just continue to strive on is look at these issues and try to make sense of the numbers.
Thank you, Carl. Okay, County Commissioner Advisory Board report, Michael Lavender.
Thank you, Mr. Chairman. Before I begin, though, I'd like to mention to Pat and Fred that it could be worse. Last weekend, I got notified that an advertising agency that the college I work for deals with, college credit card was denied. And they happened to have my personal credit card on file. And they took out all but $15 of my checking account for college advertising. So it could be worse. But at any rate, we had our County Commissioner Advisory Board meeting at the annual retreat for County Commissioners Association on the 16th of August. Meeting went well. Brian did an overview of Smoky and did a great job on that, and Shelley chimed in and helped with that, and I think it was well received. We also went over the draft that we had prepared for a suggested framework for future meetings, and it was decided that some of the things they would go along with, for example, our draft agenda, they said looked pretty good, what we thought they might want to talk about at each meeting. But they did want to change the time and location or frequency of meetings. They want to have one single meeting in Asheville each quarter, as opposed to having meetings within the region and then coming together, the point person in those areas coming together with me for a second meeting during the same quarter. So we also agreed on a day to meet, so we'll be meeting on the second Thursday, and Shelley is working to line that up. So I think that's going to go well. And what am I forgetting, Shelley?
Nothing, I think it was a really, it was a good first meeting. People had a lot of opportunity to sort of think about the meeting structure and how they wanted to meet, a lot of back and forth on that. I think it was really good that we did the orientation. We worked on a really special orientation PowerPoint presentation for the group, which I think was helpful. Michael, of course, did a great job. And I think the most important thing for us to do is, as staff at Smoky administration, as the board, is to really look at this group as a valuable group and being able to support us and the initiatives we have that we want to move forward and make sure that it's a meaningful process for all.
You decide if they can be reimbursed for travel time?
Yes, the county commissioner members, there's a policy, they will be reimbursed for, a week for the stipend as well as travel mileage reimbursement. County managers, because we're inviting them, will go ahead and pay the mileage for their coming if we've invited them to the meeting.
We can't guarantee the checks will be good, but we'll write it.
Yeah,
Mostly they have draft for
thanks a lot, Pat. Now I'll have the members come into the next meeting.
He's been Fred running on a leash for his lighting, so we will.
Are there any consent items? Is there any other business? Is there a motion for adjournment? Okay, is there a second? All in favor, say aye. Aye. Thank you, everyone. Have a safe trip back. Dinner is right outside the door.